want to talk about agitated patients real quick. And this is not maybe strictly resuscitation, but it's kind of resuscitation, or maybe it's sort of is resuscitation, because these guys are kind of complicated. There's really three, and to hit this real fast, because we got started late and I'll try to abbreviate. There's really kind of three modes of like the agitated patient. So if I need a chair. We've seen this guy. Just kind of nervous, right? Kind of nervous. Man, can somebody approach me, ask me what's going on? I need some help. I need an audience participant. Ah, perfect, yes. Hey, oh man, I'm freaking out, man. I'm just really freaking out, man, you know. That's all right. What's this? Is this guy in agitated delirium? Here's the question. Everybody's heard agitated delirium recently, right? And that's what everybody's gonna like lump to say, oh, this guy's agitated delirium. What am I doing? I'm sitting, I'm rocking. I tried to make my face red because I'm tired. I'm sweating a little bit. I'm sweating like a pig, actually. But am I an agitated delirium kind of guy? No, I'm just agitated. I don't know why. Maybe I'm nervous. Maybe I'm on something. Maybe I'm just drunk. Maybe that's. What was that? Oh, maybe that's just me. Oh, that's another one we got to buy. Maybe that's just who I am. There's the agitated person that just needs to chill out. You know, he's wrapped up. He's been in a car wreck and he's a little bit nutty acting, something like that. But he's not somebody that's dangerous. You can usually get through these people with just kind of talking them down. Even if they're on something, just because they're intoxicated doesn't mean that they are agitated delirium or that you got to really like be concerned about that. Some people are just kind of agitated, and that's most of these folks. Then there's the folks that are, we've kind of seen this too, they're so agitated that they won't hold still, but they're not really like mean to you. They're not trying to like kill you. They just won't hold still. It's the old guy, the guy with dementia that's picking at his IV and won't leave that alone. This is a guy that has a little bit of problem, you know, complying with your orders, but he's not inherently like crazy probably. He's just a little bit not able to follow commands. These are guys that for their care, you know, you could give something like a little anxiolysis, you could give a little dose of midazolam, something like that. But there's this excited delirium. If I'm sitting there and like, I get really mad that I've got this IV and I just keep like pulling at it, is that excited delirium? No, it's just a guy that's a little bit excitable about his IV. Sometimes again, folks with drugs will do something like this. Then you get to the guys that are actually in need of your help. These are the critical guys, and this is the point that I want to kind of make right now. Dangerous and may kill you. That is essentially what makes the agitated delirium part of what we're doing and why these are critical patients. And what's this guy look like? Hey! Thank you. Got a little bit of a chuckle out of it anyway. I got a video coming up here in a second that'll do it better than I did. These are guys that are so agitated that they're likely to hurt themselves or hurt you or get the shit beat out of them by the cops unless you do something about them. And that's really what kind of makes the agitated delirium part of it. Up until that point, yeah, you're agitated. You may need a little bit of medicine to facilitate us taking care of you or something like that, but not necessarily agitated delirium. The delirious part is really the thing that makes up. They're not just agitated, but they have an altered sensorium. They can't tell what's going on. They don't know right from wrong, essentially. If you look at what these guys have, pain tolerance. They're tachypnic, they're sweating. We've probably all seen these guys. You'll see them again in just a second. Interesting thing down at the bottom, everybody ever seen somebody that's like really fascinated by their own reflection? Apparently that's like 10% of these guys. I've never actually seen that part because, well, by the time I get to them, usually the guy is being held down by 6 or 7 other burlier guys. But we've kind of seen this thing. The thing about this is that these guys don't get better on their own. They don't just stop. You can't talk them down, and you can't really restrain them. I mean, you can restrain them. If you get 10 or 12 guys holding a guy down, yeah, you're going to restrain him, but he's probably going to get hurt doing it. And the goal here is that they do not respond to like the painful stuff that, you know, cops may use to try to restrain somebody. How does that usually work? Well, they grab your arm and they kind of hold it in the extent that if you pull and if you fuss with them, then it feels like your arm's going to get ripped off and you stop because it hurts. Like somebody's got your arm and you go, and go, oh God, I'm not going to do that. These guys don't have that because they're basically intolerant to pain and they're really ramped up on other stuff. So you have to approach these guys knowing that whatever you're saying to them is probably not going to help. Whatever you can physically do to them is probably not going to help. And it's your job to take these guys down in the safest way possible. As I kind of mentioned before, what are the dangers for this? What's dangerous for the patient, let's say? Well, we've all seen the sympathetic surge. They're hot, they're sweaty, they're running around, their heart rate's 150, their blood pressure's real high, they look like a sympathomimetic. They're fighting a lot, so they build up lactate in their bloodstream. They get a lactic acidosis. That goes away once they stop fighting, but they get this lactic acidosis. You break down muscles, and when you break down muscles, you release potassium, at least a little bit of it. But yeah, you can get folks in rhabdo or with essentially a crush syndrome type esque hyperkalemia when this happens. They get hyperthermic, which is not good for your heart. They do other drugs, which is not good for your heart. And then they get respiratory impairments, a lot of times because we do stuff to them, and they get hypercarbic. Basically, when you get this, your body is just taking a hell of a hit. It is constantly fighting and trying not to die, and it's really hard not to keep these people from doing that. So again, the goal, I've said it once, I'll say it again, stop them from being able to hurt themselves in the safest way possible. Again, can you do that by physical restraint? You can. Yeah, we can probably hold this guy down. Is that the safest thing for him? Is that the safest thing for us? One of us is likely going to get hurt. He's probably going to get hurt. And again, what do you often see with this? Well, taser injuries or nightstick injuries happen a lot with this kind of stuff. So you got to take this guy down without, or knowing that the physical restraint part is only there to get the chemical restraint part. This is a fairly well-known case out of Cincinnati. And you can't see him, but you can see him there for a second. He'll come back in a second. Now this is a big guy, I will grant, but he's going to fight with two cops. And there's nothing they are going to do to successfully restrain him right now. Well, I mean, they're sort of doing it, but he's still fighting. See, there comes the Billy Club. He's still fighting. Is that a normal behavior? No, of course not. But he's getting hurt when we're doing that. Now, that'll move on, and you'll see more video of that later. But how about this guy? This is another, sorry, it's not projecting real well. My apologies for the glare. But see this cat? Oh, you can't hear that. Sorry, he's going, it touched my crotch, it touched my crotch, it touched my crotch. And he's got the same thing, 6 guys and the backboard straps. And I don't think they've got him in handcuffs or anything yet. But this guy's being talked down, and the guy that's talking to him is super cool about it. He's just getting, he's not going to do it. So the goal here, when you see these folks, yes, physical restraint is part of it, but physical restraint is only there until you can medicate the person to take them down, to make them stop hurting themselves. How might you do that? You can do midazolam. I like Versed myself. It's a benzo. It doesn't interact with a lot of other things. You can't give a rat so much benzodiazepine that he stops breathing. Benzos are pretty good. And there's very few people that can argue with the sweet whisper of 10 milligrams of midazolam in their thigh. Some people can, and you can give them more and they'll still be okay. But you can consider midazolam. The other thing that folks like, is anybody using ketamine out there for agitation specifically? Just a couple of folks, yeah, a little bit. Big dose, right? Everybody gets worried when you do, oh man, 500 milligrams of ketamine. If they're 80 pounds, or well, if they're, let's not say that. Let's say if they're 80 kilograms, that's doing some quick math. What is that? 6 per kilo or something like that. The usual dose is 4 to 5. What if we give this guy too much? Okay. The big thing is he's probably going to stop fighting. After that, yeah, we're going to have to be prepared to do other things to help with these folks, but that's kind of with everybody. By the way, we're going to give this IM, and you can do this through a big needle, and you can give it through his pants. Not going to worry about sterilizing the area. If I see somebody, golly, if I see somebody like take an alcohol swab out to give one of these IM injections, Jesus, what are you doing? You're forgetting the main point. The point is that this guy is so dangerous that we got to do something to essentially minority report him and keep him from moving around so we can get him to the hospital, hopefully not to jail, but that's a distinct possibility. Once you give this, you're going to have to wait a few minutes. Don't be surprised. Nobody like gets the tranquilizer dart and then just goes down with an IM injection. It takes a couple of minutes, but the guy will fight you less and less and less and less and less. And finally, you'll be able to kind of step back. Everybody look at each other, take a big breath. All right, everything's cool. That's the most dangerous time, though. That's the problem. When the guy stops fighting, that's the part that's really, oh man, this is the part where we got to be really, really worried, because that's when these people die. Man, there was sound to this one too. Basically, this is, they're saying that, what was it? Her heart rate's like 150, so they're going to give her a sedative of some kind. I don't know what it was. They didn't say. Cool, she stops fighting. She also stops breathing, sort of. She doesn't actually stop breathing. She's just got some like airway obstruction at the top. They fix it, and she actually gets better with a little bit of positive pressure. It's not really that big a deal, but it's when the person kind of stops fighting that it becomes an issue. Because that's the point where they've lost their ability to compensate for all that acidosis they built up. They've lost any drive, not any drive, but they've lost a lot of their drive to fix all the stuff that was kind of keeping them alive. That's the time when we got to watch out for these folks. By the way, the other thing could be he stopped fighting because his heart's not working anymore. So you got to watch out for that. So we got to get the monitor on these folks as soon as we have a finger available. That doesn't have to be forward-lead monitoring, but it needs to be as soon as you got one finger out there that you can reach inside the rat's nest of like legs and arms and teeth and stuff that's in there. We need to put some kind of monitoring on there. And an SpO2 probe is probably about the easiest way to do that. That's not the only thing that we have. Come on there. There we go. It would sure be nice to get cardiac monitoring on these folks. But a lot of times they're either face down or they're face up and they're being held down by a bunch of folks. So how are you going to put 4 leads on this person? Or, you know, in this case, 12 leads. Well, we've got arms and legs, right? He's probably got secured arms and legs. Can you go 1, 2, 3, 4? Sure. I mean, it's not great. It may not give you the best tracing, but you can do it. At least it'll tell you if he's got a rhythm that is not like super bradycardic or fibrillating, something like that. Other option that we don't really think about very often, though, what about his pads? You just put pads on him, stick, done. That's super easy because his chest is right there. It doesn't really matter where it is, and I'm not looking for precision. I'm just looking for like, is his heart functioning? Do we need to start doing CPR on him? Do we need to try to pace him or do something else? That's all you gotta have. So, by the way, again, doesn't project real well. This guy is face down. This was kind of came up with the COVID stuff and how do you do prone CPR? Prone CPR. It's still funny to me. But you see he's got the pads on his like right shoulder and axilla. So you can even just put it across the guy's back. If he's face down, if that's the way that he is, there's really not an excuse to have some kind of cardiac monitor on this guy because you can go stink, stink, and those things won't come off, most likely. Cool, huh? Now, occasionally, it's nice to have those pads on ahead of time because, come on, video. You roll them over and you find, again, sorry for the lack of sound, but they're basically saying, hey, roll them over. Oh, hey, where'd fire go? Hey, call fire again. Hey, where'd they go? Because a few minutes ago, the engine just rolled past when they saw they were just fighting this guy. A lot of times these things end up with somebody, you can't see it, sorry. This dude down here is bobbing up and down because he's doing chest compressions on this guy. And that's where we're going to pick it up in terms of the resuscitation stuff. Let's say that does happen. Here he is. When you're doing this, when you're doing a resuscitation, you walk up on a guy that is, for all intents and purposes, down. And we don't really know why. Right? We just kind of found this guy. I mean, we got the history that maybe he's fighting with the cops or something like that. But you get a guy that's down or you're called for cardiac arrest or whatever. What's your goal? What's your thoughts? What's the things that are important to you? Anybody at all? CPR, okay. High quality CPR. What else you got? There's got to be something else. I'm sorry? What were the events leading up to the arrest? What happened to bring him in this area or to bring him in this state? What are the goals that you actually want to do? Like, what are the things that are important to you? What would you like to see done? Sorry, we lost him for the cleanup. What kind of stuff do you want to see happen in a cardiac arrest? I'm just asking a question. You show up, the guy's in cardiac arrest. What do you want to do? IV O2 monitor, okay. Other stuff? One more time, I'm sorry. Access, okay. Of one kind or another. Other thoughts? Something else that, sorry. Treat reversible causes. Okay. What's the important things to it? What does the patient care about? What does your chief care about? What do you care about? Those are kind of different questions. And each person is a little bit different in terms of each resuscitation, and that time changes. So I want to talk a little bit about goal-based resuscitation. And we'll give it just a second here. That's okay. That's fine, guys. You don't have to worry about it. I'll get it. Thank you. Thank you guys for doing that. Very much, very much. So, goal-based resuscitation. When you're doing this, I will posit that doing a cardiac arrest is sort of like being in charge of not a big incident, but moderate size, couple of cars or something like that. But let's take the more extreme situation. You got this guy. Now, if he goes out there and says, all right, guys, go up. That happens. I don't know. Maybe a car gets moved. Maybe somebody starts like pushing water with a broom or something like that. Maybe somebody says, we need to go check the houses, and he takes off on his own. Having measurable goals and a time to complete them is a pretty important thing for incident command, yeah? That's what all the ICS stuff, like 300 up, kind of goes along with. It's you got to have a goal, you got to have a time to complete that goal, you got to have people that are assigned to complete that goal, and not everybody does the same thing all the time. Not everybody is working on the same type of goal, but each person has a goal. I would argue that cardiac arrest is kind of the same way, because if you just take the ACLS stuff and say, you guys, go do the ACLS stuff, you end up with some pretty hairy results. So when you take an ACLS course, here's what it says. This is all the stuff I can think of that ACLS tells you to do in cardiac arrest. Is it all important? What's important? It can't all be important, but yet we teach you everything in there and just kind of say, go do it. So what do you get? Well, sometimes you get folks managing the airway first. Sometimes you get folks putting on a monitor. Sometimes you get folks calling for additional help first. Which thing is most important to the patient? What actually makes a difference for that person? What do you think when you show up, kind of the most important things are for the patient themselves? What do they care about getting? Because it's not call for additional resources. It's not C-spine. Somebody say it loud. I thought I heard something. Getting oxygen to their brain. Okay, love it. And that's pretty much it. Brain and vital organs getting resuscitated. Which of these things kind of does that? It's on there somewhere. Chest compressions. Yeah. There's another thing that they really kind of care about, and that is whether or not they're going to eventually come back, whether or not their heart is eventually going to start again or work well again. And where does that fall into? That actually is the shock part. So when you roll up on somebody, he really doesn't care how many people you have. He really doesn't care how you're planning to manage the airway that much, as long as it gets managed, or what kind of difficulties you may have, or if you're going to talk to his family. All he cares about is, hey, my brain is not getting blood and it's dying, and I need something to fix that. And so chest compressions become the most important thing. The second most important thing I would say will probably be delivering a shock, and here's why. Chest compressions make sense, right? Got to get blood back to the brain. What about the shock? Well, there's this thing called the three-phase model of cardiac arrest. This is based on the idea that when you die, when you arrest over here, switch this up a little bit, you start into the electrical phase of cardiac arrest. So you start to fibrillate right here. Your myocardial juice goes down substantially over this first 4 minutes thereabouts. But in that first 4 minutes, a lot of times it's not a problem so much that like the heart can't beat. It's just got some weird rotor currents getting set up, and it's got a weird electrical storm kind of going on with it. But if you shock it, if you stop it from doing all that, there's a good chance in the first couple of minutes that it's going to kick right back in and do what it does. Your SA node and your AV node pretty well work pretty good for the most part. It takes a lot to really actually kill them off to the point that they won't beat, although sometimes that does happen. But in those first couple of minutes, you have a chance to bring the person back with just a shock usually. Now, that doesn't always happen because where do we kind of end up showing up? Yeah, out in here in the 6 to 8 minute range. So after about 4 minutes, you've gone from the electrical phase where electricity is likely to really help this person to the circulatory phase of cardiac arrest. Juice for the heart, ATP, oxygen, whatever you want to call it, has gone down. And now it's to the point that the heart's just going to have a hard time coming back. You may stop the fibrillation, but the heart is probably going to go into asystole after that, or has a better chance of going into asystole after that. So you move into the circulatory phase of cardiac arrest. And that lasts for about 10 minutes. The goal here is to try to restore blood back to the heart and make the heart a little bit better and kind of push it back to that electrical phase where hopefully you can deliver a shock and make things better. After about 10 minutes of like no treatment, essentially, not only do you have problems with the heart and that it just doesn't want to come back, but you have problems with like free radicals going through the body, and you get this whole body kind of crush injury thing, and you get potassium going this way and calcium kind of going this way, and there's all kinds of crap that happens that makes it really hard to get somebody maybe not back, because again, the heart is a dumb organ. You can give it a little bit of blood and it'll just beat all day long, but the brain, the kidneys, the liver, the gut, all that other stuff runs into real problems after you get to about 10 minutes of essentially no resuscitation. The point of CPR, of chest compressions, is, come on there, to try to stretch that curve out. If you get bystander CPR, you may be able to stretch that electrical phase out to, say, 6 or 8 minutes, when there's a chance that you might be the guy that responds. Maybe if you're getting really, really great CPR, you can stretch it out for 10, 20, 30, maybe more minutes. You still run into some problems, but the idea behind the chest compression is to bump that line up to deliver some substrate to the heart so that you have a better chance of either getting it to work again or going back to the electrical phase where if you shock, it'll get better. That's the 3-phase model for CPR. There we've said it. Kind of cool. Yeah, you may not have thought about it, but that's the idea. So what's the most important thing when you show up again? It is put on good chest compressions or some chest compressions, but good is better, and then deliver the shock. And why is that? Well, number one, you're doing the chest compressions to try to stretch that time limit out. And number two, you're trying to deliver the shock as early as possible in as most cases as possible. So if we're going to put a goal to it, when you roll up on somebody, the first thing you should think is, oh my God, he's in arrest, or you'd say not breathing, not waking up, as AHA will do. He's in arrest. What do I need to do? I need to start chest compressions, and I need to make my goal that we're giving a defibrillation shock, if appropriate, within 2 minutes. Maybe it's not always appropriate. And that's not to say that these are the only two things you have to do. Obviously, it's not one person pushes and then one person hits the button. It's that you got to drive to that. You got to have the pads on the person. You got to turn on the monitor. You got to look at the rhythm. You got to do the rhythm check or the pulse check, whatever you want to call it. All that kind of has to happen within 2 minutes. But at the end of 2 minutes, your goal needs to be, we've delivered a shock, or we've at least checked to see if it is. And that works out pretty well. If you avoid all the other stuff going along with it, like you forego the airway, you forego the IV, don't worry about the Lucas right now. If you just do chest compressions for the first couple of minutes, your survival is markedly better. So this one here is if you delay even just bagging and just focus on chest compressions versus immediately starting to bag the patient, survival is pretty different. Same thing with their neurologically intact survival. Pretty much better, about double, maybe 3 times what it was if you just bag the person. If you just focus on initially those good chest compressions and delivering a shock when it's appropriate, you get better survival. And this was old data. This is like 2006 maybe or something like that, 2008. This has been out there for a long time. Maybe we haven't quite adopted it yet. All right, so we've done our first 2 minutes. What's our goal after that? Well, now we're getting into that point where even if we shock, again, there's just not substrate in the heart to get it kicking again. So now we want to restore perfusion. How might you do that? Well, good chest compressions and potentially continuous chest compressions and continuous good chest compressions, because not all chest compressions are the same. We'll talk on that in a minute. I would say we should start adding in upstroke ventilation or uninterrupted ventilation. I'll show you that in a minute as well, within a couple of minutes, because if you don't breathe for the person, they do also not do so well. Airway management needs to happen in some way or another by about 3 minutes in, with waveform Untitled CO2 monitoring. Now we can start talking about giving epi and getting vascular access, that kind of stuff. If we're going to do it, it probably needs to happen early. So we should probably get it done in the first, again, 5 minutes or so. And we should give a bolus of fluid, if possible, or if that seems like it's a good idea, within the first, say, 8 minutes or so. And that may seem like it's kind of tight, but it's pretty possible with even a crew of 4 people thereabouts. And these guys did a lot of that stuff. After 10 minutes, you kind of lose the ability, or we kind of lose in the pre-hospital setting a lot of the important stuff, or the ability to do a lot of important stuff. So identify the cause of arrest. I mean, most of the time, everybody, I myself, same thing, like, well, why did he die? I don't know, probably heart. Probably heart. If it's an adult, probably heart. Maybe not, but probably, just because that's the easy thing to kind of fix. That's the one thing we can do kind of something about. Once we get to more than 10 minutes and we're in that metabolic state where we got to try to make things a bunch better, the goal is, it probably becomes less, can we get this guy back, but how do we limit the metabolic damage to him? So you can start things, eventually you may start talking about pre-hospital art lines, maybe not, and titrating blood pressure. All that stuff, yeah, hydrocortisone for refractory collapse. Surprised that hasn't come back. That was 2013 when it was kind of the hot topic, and then it died, as most things that are new in cardiac arrest do. But these are good things to keep in mind. This stuff is out there. And yes, this is stuff that you may not be able to do in the field right at the moment, but that's probably where we need to go after you do the initial stuff that we talked about on this page. So when you get out there, after you get to more than about 10 minutes, yeah, you got to be kind of thinking, man, is there something else I can do for this person? Is there somewhere else I can take this person that it works, that may do something more for them? Or is this futile in general? And do I really need, as what you see on that bottom, is this something we should really continue to do, or are we just going to kind of buy time until we say it's not going to work? That, of course, assumes that you haven't found a reversible cause. So if the person's choking, if they're eating a hot dog and they choke on it and they arrest as a result, you got to fix the hot dog part first. You got to get the hot dog out of the throat, or the guy's never going to come back. So that probably becomes your #1 priority. Maybe you can defer chest compressions for that. Say you got this guy, he's down on the street. Why is he arrested? I don't know. But you do some investigating and you find out, maybe he's got a stab wound to the back. All of a sudden, fixing the stab wound and resolving the pneumothorax, if that's the thing, that's kind of the most important part. So we can defer a lot of that other stuff. Maybe chest compressions aren't the thing that really helps in this case. We got to fix the reversible cause. Now, it's not all the time, but again, it's maybe part of it. The thing to remember is that the algorithm is not management. It's not how you fix cardiac arrest. This is just kind of the program to put in, to fall back on, to kind of keep somebody going a little bit, to try to restore a little bit of blood flow, to try to maybe give them the chance, to give them the life support. This is not how to get somebody back from the dead. This is just a means that you can kind of implement that, a unit clerk on a hospital could theoretically run. Somebody who works in a setting where you're not around arresting people all the time could probably run. This is crap stuff for us. If you're in an emergency setting, or if your job is to manage cardiac arrest, this is just the basics. And I'm not saying don't do it, but there's so much more to it that we've got to recognize. The emphasis on the algorithm being the #1 thing has to kind of go away. Good chest compressions, yes. But if you find something and you deviate from the ACLS algorithm, is that a problem? Well, no, not really. Did the person come back? Did it work? If it does, all right, cool. That's great. It's always a moving target, and you got to kind of follow that target around. Excuse me, my voice has stopped working all of a sudden. And so depending on what time you're at in the resuscitation, what may be important to you may not, may change quite a bit. So again, to look at continuous chest compressions and a defibrillation shock given within 2 minutes. Does that make sense? Yeah. Here's survival data. We talked a little bit about like the CCR, the stuff I showed you at the beginning. Here's what happens if you get, where'd it go? Chest compressions. I lost my pointer. There it is. Chest compressions versus not chest compressions, and how long you've got to give a shock. You can stretch it out to about 7 minutes or so if you focus on those good chest compressions and make that your priority. That's quite a bit less if you don't get chest compressions. It's also an interesting point, like most of us are going to arrive, you know, what's your arrival or what's your response time for a cardiac arrest? 6 minutes, 8 minutes, something like that. If you're out in the middle of the county, someplace it may be 15 minutes. Look at where survival goes, even with chest compression. It just really falls off. Here's again, 15 minutes out, which is, you know, a medical director out in Powell County. That's not uncommon. Like, that's a bit of an issue. About half of what it was to start off with, and that's before you do anything else. Before you even roll up on the patient, is likelihood of coming back is significantly less. What's that really tell us? Well, what it really tells us is all the stuff that we're doing is kind of important. The telephone CPR stuff, that's the thing that's actually really, 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 really important for cardiac arrest stuff. But we don't have a lot of, is anybody a dispatcher? Do we have any PSAP folks in here? It's okay if not. Cool. Those are the guys we got to kind of focus on, because they're the ones that are actually going to implement that. Can we get this done in 2 minutes? Do you have an AED? Can you push on the guy's chest? Those are the guys that we need to rely on to stretch this out and to make our goals worthwhile. All right. So let's hit play. All right. You're called for, I don't know, he's a 36-year-old man who clutched his chest while he was mowing the grass and fell over. And he's been unresponsive since then. His wife saw him do it. It happened about 4 minutes ago. And he's all yours. Unresponsive. You do not feel a pulse. All right. That'll work for the moment. You guys can stop for a second. All right. So what do you think? What's going on? How are they doing? I realize, I'm sorry, it's a little bit noisy in here. I know you can't hear some of what they're saying. But what would you say about how they're doing so far? Everybody's doing good because everybody's, yeah. So. Okay. How many shocks did you guys give total? 2 thus far? Okay. So, all right, when we start talking about like, you know, are you meeting goals kind of thing? This is, you know, Walt's goal is get the shock in 2 minutes. That doesn't necessarily mean that I'm right, but for the sake of this like conference, yeah, right answer, cool. So did we do that? Yeah, sounds good. What was the other goal for the first couple of minutes? Compressions. Did they do chest compressions? They did chest compressions. Did they do good chest compressions? We can maybe find out. Maybe they did good chest compressions. Maybe not. Who's to say? Say Alan probably says they were excellent chest compressions. Could not be better. We'll talk about it. So we're into about the first couple of minutes of the thing, yeah? We've done the initial stuff. They did a good job of getting the pads on. One, you know, I know that this is different equipment than you probably have, and it's probably a little bit easier when you got your own kit. But overall, good job at figuring out all this stuff and getting those first couple of things done. Sweet. You guys kind of got the easy part for now because you only had 2 things you had to do, and you did a great job. So go ahead and take a seat again. And can I get the next table? We'll say Abby included. Come on. Sure. All right. So they're going to pick up in the exact same spot. They showed up. This is, again, if you didn't hear, he's a 6-year-old man that collapsed while cutting breast. He's gotten 2 shocks so far. They have established an IV, and I think they've just been bagging him otherwise thus far. Sound about right? Good deal. You guys didn't give any drugs this just yet, right? Wonderful. Okay. I'll give you guys a second. 2. Yes, sir. The team got eaten by a bear. I don't know, a down or something like that. And 1, 2, 3, shock just happened. He's all yours. Those things. But as I've kind of mentioned or alluded to, that may not be everything for cardiac arrest management. There may be some other stuff about how we're doing all that stuff that makes a difference. So let's see. Let's talk chest compressions. Please work.
We will now induce ventricular fibrillation.
Can you guys hear that? You probably can.
The cardiogram shows that the heart is fibrillating. The blood pressure falls to zero,
sorry.
as does the
So this
carotid
is
flow.
from
The animal is in
1967,
cardiac arrest.
and this is William Cohenhaven, who is kind
We
of
now begin
the
closed
guy
chest cardiac
invented the guy
artificial respiration.
Just Cohenhaven, he's the old guy. He was actually an electrical engineer that got hired with the
Blood
intention of
pressure rises,
there are a lot of line
and the
workers
blood
dying.
flow comes up.
The other guy that's with
The
him
heart and
is
brain are thus kept
Knickerbocker, who's a
oxygenated
doctor,
until
and then
external
June was there.
defibrillation
A
can
little bit
be
of MS
performed.
history, but
To demonstrate the
you see the chest
effectiveness of
compressions
this
he's doing.
method
This
in
was
maintaining
revolutionary at the
useful
time.
circulation,
The video I have
will continue
of sort of a
external
similar thing
cardiac
about 8
massage
years
and
earlier, there is no closed chest CPR. It is you open the chest and you reach your hands in there and you squeeze it. And this was a big thing, like from the turn of the century onward, essentially, maybe more in the 30s and 40s, when there was not really an emergency department, there wasn't really like a standard EMS or something like that. If your friend died, you threw him in the car or over the back of a horse and you carried him or whatever, and you tried to take him to the local doctor's office, and they put out a fair amount of training about here's how you do a thoracotomy. And so your local doc would thoracotomize you, reach in there and start squeezing. And that was it. Like, that was what we had. And it wasn't until it's really fascinating, like up until the 60s, there was no CPR, no effective CPR. There was stuff that we did, but no effective CPR. Apologize, it's so noisy and that we're getting feedback issues, but it's just kind of a cool video to see. The CPR that he's doing, though, looks pretty much the same as what we were doing, right? Guys, everybody that was doing it, like, that looks pretty darn familiar, including that he's not bagging anybody right now for the first little bit. So let's talk about chest compressions. Chest compressions, while they haven't changed a lot since the 60s, they are a skill. It is not something that you are inherently born with. It's not a developmental stage. You don't like kind of learn to crawl and then you learn to pick up things and then you speak 2 words or something like that. It's not something that you're just going to kind of figure out, although we sort of lead people to believe it. When you take an ACLS class, what do they do? You do that little bit of the BLS thing at the beginning. Like, all right, do chest compressions. Okay, well, like, there's actually a lot to a chest compression. It really can make a big, big difference. And I realize that we're no longer online. There we go. So, how do we know about chest compressions? Here's what AHA says about chest compressions.
You can tell by the way I use my walk, I'm a woman's man. No time to talk. You see love when they walk, they get to match. That's how I want to what I can, and you may look the other way.
All right. What's the thrust of that? Again, the thrust. What is the message that AHA wants you to take away from their commercial there? What, I'm sorry? Yes, yes. He comes in just a second. The video stopped too early. Yeah, Dr. Ken will slide in there and do this thing. This goes on for another like 3 minutes. So we spent a lot of money on this commercial. What do you take away from it? Hard, fast, and deep. What do we tell people? You know, and that's right. That's a good message. What do we tell people about doing chest compressions? Say it loud. Everybody knows it. push hard, push fast, right? Push hard, push fast, push hard, push fast. Cool, that's great. If you want to get people who have no idea what they're doing to do CPR. If you just want the guy, like one of these guys that was just walking past here, if his friend dies and you want him to do some CPR, you tell him to push hard and push fast. Don't worry about blowing in the guy's mouth because that's gross. You do everything you can to make it kind of simple because some chest compressions are probably better than no chest compressions. Yeah, and that's probably true, but that's not good enough for us because we're professional lifesavers. This is our job. It would be like sort of between me making a steak and you going to like Ruth's Chris. Our steaks are probably going to be a little bit different. I will still make you the steak, but despite what I'm really trying, I'm just not going to do it as well. That's kind of probably the way I think of us doing chest compressions as well as the airway stuff, the BVM stuff, all that kind of stuff. High performance CPR. Come on, graphic. There we go. What is high performance CPR? You probably heard this, maybe. Maybe it's been kicked around a little bit like this. The actual high performance CPR was something that the Seattle guys kind of kicked around to start with and brought up. What makes high performance CPR? Well, it's good CPR, right? Yeah, sort of. High performance CPR is taking metrics, taking measurable things and applying it to how you're doing CPR in order to come up with the best outcome. So there's basically 5, 6-ish things that you can objectively measure about how you're doing CPR that has a direct bearing on whether or not the patient lives or dies. It's not just do chest compressions and chest compressions as a thing. There's a whole bunch of different things that you can look at about how you're doing chest compressions. So we luckily get to talk about all that now because it's important. All right, so how deep are you pushing? Do I know what the recommended depth is? Sir, 2 inches, okay? 2 inches is the top or the bottom. Maximum depth or minimum depth? You know, yeah, maybe something like that. Like what is a third of the depth of somebody's chest? Which put out there, I have no clue what that is. And it makes no sense to me why somebody would say push a third of the, I don't know what's a third of my chest? Like here? And then pushing down on it, how do you know that? That's the but yeah. So the recommended depth is 2 to 2.4 inches. Which looks something like this. Where does 2 to 2.4 inches kind of come from? Is there really a top to that thing? Excuse me. Here is the research behind it, or at least some of the research behind it. If you, your tracks there, you look at that line in the center, that's probability of survival, and depth of pressure, chest compression goes up. You see that you reach a peak somewhere right around here, around 45 millimeters or so, which is somewhere around 2 inches, and then it kind of falls off after that. Now, there's question about whether or not it truly falls off, but it probably does. Why might it fall off if you're pushing too deep? Well, you squish the heart too much, you don't come all the way back up, you get tired faster. There's lots of reasons that could happen. But the best survival seems to happen right at around 2 inches, 2.4. What's the difference between 2 and 2.4 inches? 4/10 of an inch. Okay, cool. How big is 4/10 of an inch? Anybody want to guess? Just hold up your fingers how far you think 4/10 of an inch is. Come on, everybody do it. Come on, come on, come on. So it's an interactive conference. 4/10 of an inch is the width of a pencil. That's a small little target, and it kind of probably makes a bit of a difference. Now, nobody's going to ask you to be exactly 2.4 inches every single time. And if you go a little heavy, that's probably okay. But kind of bear in mind that that's what the actual data is out there. Why we kind of say 2 to 2.4 inches is because of this. Because if you push too hard, it seems like it's not as good. So right around 1.8 inches thereabouts. All right, that's depth. Depth is hard to do. And do you know exactly how far you're traveling when you push down? Not really. You kind of got to get a muscle memory for it, which is why some of this equipment's important. Why you should train on it. All right, how fast are you going to push? Everybody's got an idea on this one. I know you've heard it. Somebody, how fast? What's the bottom number? Between blank and blank. 100 to 120. All right, cool. And what's that based on? Again, you take the study. You look at it. There's 100 to 120 in that green bar. It correlates more or less with the best survival in these little blocks down yonder. The curve falls off just a little bit. The actual peak of the curve comes at like 124, but when you do the statistic stuff, it comes out to like 100, 120-ish, thereabouts. Cool. Now, take that away for a minute, and let's say that you don't hit 120. Or you don't hit 100. Let's say you go 20 beats per minute on either side of that. So you go at 80 or you go at 140. You'll look at the survival, and you find the odds of survival for going a little bit too slow, 20 beats too slow, is better than going 20 beats too fast. That's kind of interesting. If you take it out to 160, then it's significantly better. Like going 20 beats one direction or another really makes a big difference in these folks. The key is probably that we usually go too fast. And you may say, well, I don't know anybody that chest compresses at 160. I bet you probably do, though. I bet you may have done it before. We can use audio prompts to kind of help us explore this. And my apologies that it may not play real loud. What's this one? Staying alive. What tempo is staying alive?
Well, you can't tell by the way I use my walk.
That's 100. It's all about 100. If you're pushing on somebody's chest like that. If you're doing it in a hospital, a nurse is probably going to yell at you, speed up, speed up, speed up. All right, that's 100. Don't go any slower than that, or try not to go slower than that. Probably nobody's going to. What's 120 look like? We got any thoughts on that one? Come on. That's 120. Don't stop moving, it's 120. What on that one?
Just a small town road.
Feels a little bit slow when you push on it. It's about right. Awesome. Falls right in that 120 range. So the graphics are doing weird things. How about 160? How fast does 160 actually go? Not that doctors are, all that great at chest compressions, but I'm saying we all do it. No matter who you are, we all push a little bit too fast, usually. And it's probably better to back off, go a little bit slower rather than a little bit too fast. But you got to pick something, think Don't Stop Believing, because it's an awesome song. And it probably gives you the best survival. All right, we did the rate. We did the depth. How about release? What's release mean? What? Yeah, when you go down, you got to come all the way back up. And you got to come all the way back up each time. This was a pig study, but this is illustrative of what happens. If you leave the chest squished by just about a quarter of it, 75%, you just don't come back. You come up 3/4, but not all the way. Survival, or you do not generate enough perfusion pressure to get blood flow back to their coronaries. You leave the heart squished because it fills during relaxation. So you're not only you're increasing the pressure, and you're not letting it fill up entirely, and you're not letting the coronaries fill. Long story short, if you don't come back up all the way, you never get enough blood flow to the heart to actually bring the heart back and get it started beating again. And I think we find this a lot because this is much more prevalent, as you'll see in just a second, than you probably realize. What's 75% of 2 inches? What would that be? It's 1.5 inches, something like that. Even 2.5 inches, it's right around that. So that's a quarter of an inch. If you leave the chest compressed a quarter of an inch, survival is not very, very good. You're not going to get the heart back. All right. Push hard and push fast. That's what we've heard. That's what we've said. That's what we tell people. And still, again, great for the general public. For us, we can do a bit better. We can do something else. We push correctly, and we don't stop. So, are you doing that? Are you doing that in your service? Are you doing that in your resuscitations? Did we do it in this resuscitation? Did we meet those things? Most of us get it. No idea. Come on, somebody laugh, please. Oh my God, I'm dying. No, most of us have no idea. It's hard to tell that stuff. Yeah. When's the last time you got debriefed on a code for cardiac arrest and you got to see your CPR data? Somebody out there is surely doing it. They're like Jessamine County people out there, you try hard people. Yeah. It's a bunch of tryhards. It's hard to do. We'll talk about it a little bit more this afternoon. But to actually see, and it is very much available on pretty much at least the Zols and the Physio. Physio still has a puck, right? The thing you can push on. It does it on its own now. Sweet, nice. It was you guys that had the extra puck you had to put on there. Who was that? Well, there's Zoll that has the pads, and then there was another one where you had to buy like a separate device itself. I swear that was like, maybe I'm wrong. But yeah, basically all the monitors that are out there let you do it in one way or another, or at least you can kind of look at it. But yet we just kind of don't. And so it maybe isn't that big a surprise that our survival is not all that great. Anybody know what the survival from cardiac arrest is in Kentucky? Is anybody from, Jake's from outside Kentucky, but anybody else? Survival nationwide is about 6%. About 6% of the people will, with good survival, about 6% of the people will walk out of the hospital and feed themselves, pay taxes, wipe their own butts at the end of the day. About 20-25% of the time will get ROSC in the field. If you don't get ROSC in the field, the chance of survival ultimately is less than 1%. So if we collectively bring somebody to the hospital whose heart is not beating, there is a 99 point plus some odd % chance they're going to die. So we got to do these pretty good. And there it just says the same thing I wanted to say. All right, what I wanted to do was look at the resuscitation that we just did. Okay, starting at the beginning. Here's the way that you read these graphs. This top one is the squeezies and blowies. This is the volume and for how long that volume is in the chest. You can't use it too awful much because it's got a lot of leak and the airway's got a little bit of, but it more or less gives you your breaths. These are chest compressions down here. You start at the top and then you push to get down. This green bar is 2.4 inches. So between here and here is what you're trying to push down into. And then you're trying to get that red bar to go all the way back up to the top. This is just monitoring where the position of the thing is. So here's the arrest that we just did. Let's look at some of the things that happened. All right, from the beginning, and I don't remember who was who, so hopefully nobody's embarrassed or anything like that, because it's all just a learning experience anyway. But in the beginning, we said, all right, I started you at the 0 and said, go. And we started doing some stuff. So we got some bagging going on in about 45 seconds, and we got some chest compression started. You notice that the chest compression doesn't actually quite get down into the gold bar. Like, we're pretty close, but it never quite makes it. We get a pause here. I can't remember what this pause was. Then we get another little pause here. This was, 4 seconds or so. And then this one was a little bit longer. Right at about 2 minutes. We're probably getting ready for a pulse check here. And the one thing I wish I could remember, and maybe somebody can tell me, you notice that as you go through, I think we had the same chest compressor. I don't think we actually did a switch. So back at that 155, way down at the beginning, that's when we would have had our shock or our pulse check, or maybe change or whatever. You notice that CPR quality is getting less and less. So we don't release quite as well, especially kind of back through here, and we don't push quite as hard. And that's a common occurrence. That's real common. It is awfully hard to do 2 minutes of good chest compression, like effective 2 inches all the way back up each time. It's probably easier for us, for out of hospital folks, and probably easiest among like firefighters especially, because you just gotta have a big torso to be able to do it. To physically be able to do that, that is a hard thing to happen. And most people can't really do it for more than 2 minutes. Something like that. Okay. So we did it. You see that
Anyway, we didn't quite hit it. That's when we paused. Our pulse check was right here. This 320 to about 326. And it was about 5, 6 seconds long. That's pretty good. I like that. I think we gave a shock in that time as well. Then we got this intervening time period where I was talking and I had to switch. And we get some more chest compressions. And here we start off pretty good, but if you see where the arrow is, you notice a lot of leaning. It never makes its way back up to the top. We get down far enough, it just never actually comes back up all the way. The total travel time is probably about the same, but this is that magic like 1/4 of an inch that keeps somebody from being able to come back. Even though, you know, the compressor is pushing hard, but it's just not coming all the way back up. And we'll see that actually get a little bit better as the person gets a little more tired, because usually it's because you can't push real hard anymore. Okay. We've got a pulse check here. This was a little probably artificially long because they were asking the questions, but if you think about it, here is our pulse check, and it was 30 seconds before we started doing any more chest compressions. It's a little bit of a long time. And then we did another one that was about 5 seconds long after that. Let's see. Oh, went back to the beginning. And I've been talking in the meantime. Here we go, last little bit here. That'll do it. Okay. So, it's not that there were other ones in here, but it's just hard to navigate around the thing holding it still. So it looks like we're doing really good chest compressions this whole time. But you come to find, maybe not as great as we kind of thought they were. At least objective. Now, aid for effort from everybody's standpoint all the time. And again, all of us, when we just looked at it, we all said, yeah, those are good looking chest compressions. But when you actually go back and review it, you come to find maybe they're not as hot as we thought they were. Question, sir? I do actually have it from the last one. We'll get another one here in a minute. We'll see it in vivo. Good question. All right. So the point is, don't feel bad about your chest compressions because we all do them exactly the same way. Let's just look at how we might be able to improve them a little bit because they're really, really, really important that we do really good chest compressions. And how do you do it? How are you going to know that you're doing it? You got to measure it and you got to practice it. Oh yeah, so we talked about the, here we go. There we go, all right. We talked about high performance CPR a little bit thus far. We said it's a way of looking at objective things that make a difference to a patient because they matter in survival and neurological intact survival, all that kind of stuff. We hit so far just chest compressions. We spent the whole time just learning about chest compressions this far. Rate depth recoil we've talked about. Let's talk about the airway stuff, the ventilation, the respiratory rate. And by the way, beer is available whenever you want it. So it is not free. Sorry, we don't have that much money. But I would really appreciate it if everybody could go and get one before the end of the day, or two, or several, so that we meet our minimum so I don't have to pay any more for it. Yeah? Cool. All right. Anyway, let's talk about airway breathing, and let's talk about airway breathing. I was going to say ABC. So, chest compressions, airway and breathing. We've seen this for a while, yeah? We've said how important how important chest compressions are to the detriment of maybe we don't need airway and breathing. We've really focused on just chest compressions. This is the CCR algorithm. That's that same data I showed you before, where if you don't bag somebody for a couple of minutes and you just focus on doing chest compressions and shocks, that you get so much better survival. That's been out there, and again, this is like 2006 or something like that. That's kind of cool. However, perhaps the old thought of, the guy with his laryngoscope while somebody else is doing chest compressions and the thing's bouncing up and down and you're like trying to sneak in there and hey, hold CPR for a minute so I can bag this, or so I can get this airway or something like that. Yeah, that's probably not a great way to go anymore. You can even say when you look at it, is there a difference in, let's say, intratracheal intubation versus eye gels? This is, what was this? This is Airways 2. So is it better to intubate somebody versus put in an eye gel? Well, turns out it doesn't seem to make that much of a difference, all told. About the same. How about if you look at a king versus intratracheal intubation and cardiac arrest? Yeah, you can talk about quality and the weird kind of outcome measurements that they use and say, in this history analysis, airway device on enrolled patients, there was no significant difference in 72-hour survival. Whether you put in a king airway or whether you intubated the person, survival seemed to be the same, and that carries through on secondary analysis as well. When you look at these guys, they just said, well, do you need to intubate them at all? I referenced this a little bit ago. Here's survival. Oh, there we go. Sorry. Here's survival down here. If you put in a supraglottic, here's if you put in an endotracheal tube. Here's if you put in just BVM and just put an OPA in. That's a big difference. And that should be kind of surprising to a lot of us because, again, when I asked before, like, did we manage the airway? We were a little bit like, yeah, kind of. But remember that airway management doesn't have to be an endotracheal tube. It doesn't even have to be a supraglottic airway. It could just be a BVM. Then one of the things that has stuck in everybody's mind, and again, from the early 2000s, this Ochter-Heidi paper, death by hyperventilation. Basically, if you bag somebody too fast, their survival is low. Now, this part was actually on pigs, but they saw the same basic thing. You see the same basic thing in the hospital. If you ventilate a pig at 12, you almost always shock them out of it. If you ventilate at 30, you can almost never shock them out of it, even if you give it a chance to come back and slow it back down. If you ventilate somebody too fast, it's a bad thing. And their average time for, or average rate for breathing in this was in hospital look, was 37 times a minute. 37 times by doctors, nurses, people who should know better, respiratory therapists, squeezing the bag 37 times a minute. And again, you may say, well, I never do that. Sorry, it doesn't project real well because it's a little bit bright, but right here is a paramedic's hand squeezing the bag, and just watch how fast it moves. 1, 2, how fast is that person going? About 36 times a minute. That happens. It's out there. We all do it if we're not paying attention. Now, we shouldn't do it, but it does happen. So it's really not that the airway and breathing part is not important, and I'll show you why in just a second. It's that you have to do it right. It's kind of like chest compressions. It's not okay to just kind of half-ass it. You got to do it right. Here's some of the data that says why it's important. This was, again, a pig study, but pigs are easy to keep track of and do cardiac arrest stuff with. You find that pigs that got ventilated during their cardiac arrest did a lot better. This is median swine neurological deficit score for however it is that you tell if a swine is brain injured or not. Pigs that got ventilated did a lot better than pigs that didn't. And pigs that got ventilated had a lot better CPC, again, just a neurological performance score, than pigs that didn't. And it was a lot easier to resuscitate pigs that got ventilated, significantly so. In the end, you end up generating a bunch of tax-paying pigs if you give them breaths versus nursing home pigs if you don't give them breaths. And we need to bear that in mind. It's not that airway and breathing is not important. There's just other things that we can kind of do, and we got to be able to do it right when we do it. So consider just bagging these folks. My big take home is consider, if you can, just bagging them, but you got to bag them right. You can't squeeze a bag 50 times a minute. You also, no matter who you are, you cannot hold a one-handed seal for any good length of time, any meaningful length of time, and still get good breaths in and not insulate the stomach and not screw it up. You cannot hold a one-handed seal for any length of time. Stop trying to do it. You need two hands for it. It's just not going to work otherwise. And if you say you can, I would challenge you, and I will prove that you cannot. I retweeted one guy who said this one time, and the entirety of Europe and all their anesthesiologists said, well, that's bullshit. Well, maybe if you have ideal patients who have no facial hair, who have been fasted for 24 hours, and who are coming in for elective surgery, yeah, you could probably bag that person one-handed for a little while. But our cardiac arrest folks, our emergency folks, you can't hold a one-handed seal. You got to use two hands. Use two hands. BVM is a two-person job. If you can't bag, you should improve your bagging. And you got that's another talk. And I think John Osterman is going to talk about that tomorrow. All right, how about intubation itself? One of the other things, and even supraglottic placement, one of the other things that we find that probably makes the idea that we are managing the airway is not important, or maybe managing the airway hurts people, is the amount of time we spend in pauses. So in this study, this was of doctors and paramedics, I believe. Average time to pause chest compressions for an airway of whatever kind, 109 seconds, almost 2 minutes. Almost 2 minutes, we're just like, stop. I'm going to intubate this guy. 2 minutes later, okay, now you can start chest compressions again. It was broken up, yeah, I understand, but 109 seconds of pauses just for the airway. Up to 8 minutes of pauses just for the airway. And again, if you say that can't happen, it does. I've seen it happen. Thankfully, I did not bear any responsibility for it, but I've seen it happen. We spend a lot of time doing it. We cannot stop for an airway. We need to manage the airway otherwise, but we can't stop doing the chest compressions just to get the airway. Unless it truly is the airway that got us into it and we need to do a crike, or we need to get the hot dog out of there. And the only way you can get the guy to cough up that hot dog or get your McGills in there is if you have a pause in the CPR. But everybody else, pretty much, there's never a reason to stop for an airway. I mentioned this a little bit before. It is just fine to bag somebody through their entire code, except your hands are going to get tired. Because you see the way this person is doing it, that is ineffective and you should not do that. That not only is it just kind of smushing the mask on the patient's face, of course there's no two hands on it, but you see people do this. Again, yes, this type of bag, not cool. Manage an airway through the entire rest. Yes, I will take it. That looks good. Put another guy with a bag on top of there, another gal with a bag up there, give them gentle squeezes every 10 seconds or so. Yeah, that was money. Love it. Put a PEEP valve on there, you'll be even better. The only problem with trying to bag somebody through the whole code, as everybody has no doubt felt, try to actually hold that good seal for a while. Now, I will tell you that I think in cardiac arrest, PEEP is probably important. We kind of go away from PEEP, and in fact, the ITD that you all seen the little rescue pod, you remember that thing? A little like $80 one-way valve. I will actually contend that I think, and I have data to back up, that PEEP actually makes a difference in terms of oxygen delivery. And there it is. So being able to hold PEEP on a patient, actually, if you put it at 5, and even if you put it at 10, has equivocal oxygen delivery, a little bit better at 5. PEEP keeps that atelectasis down, keeps blood flow through the lungs, works a little bit better. That's hard to hold that person the entire time, though. Yeah, if you really grab somebody's jaw and you do it right, your hands get tired really, really fast. Mine do. The other day, I did one on a guy that we were trying to delayed sequence intubate because he was COVID and hypoxic and fighting and all that kind of stuff. It was the exact same thing you talked about. So I ended up holding his face as much as I can. After about 4 minutes or so, my hands start shaking like that. Oh, God, guys, I got to stop. Can somebody else do this? No? All right. And so you keep doing it. But yeah, it's about 5 minutes. Your hands get really tired and it's about time to switch out. So maybe we can't do that all the time. Maybe there's something else that we could do. Maybe it is put in a supraglottic airway if you just got nothing else. It might be intubate the guy. If you can do it real fast, and he's an easy airway or something like that, yeah, I would say go ahead and intubate the guy. As long as you don't stop for it, and as long as you don't leave him for like 6 minutes with no breaths, that's probably a reasonable thing to do too. There's another place where we lose time on chest compressions though, and that is kind of what we were doing before, what we mentioned before. So what does, without an advanced airway in place, what's the AHA guidance on bagging? 30 to 2, 30 chest compressions, 2 breaths. 30 chest compressions, 2 breaths. That's lightened up a little bit on the most recent guidelines. It's maybe, there could be other ways to do it. but they say 30 chest compressions, 2 breaths. Okay, here's what 30, this is pressure, blood pressure. Here's what 30 chest compressions and 2 breaths looks like. There's chest compressions, there's 2 breaths. There's chest compressions, there's 2 breaths. It's almost the exact same amount of time. You take 10 or 15 seconds often to do 2 breaths and let them fully expand before you start doing chest compressions again. So 10 to 15 seconds of chest compressions, and then 10 to 15 seconds of sitting there bagging them. 50% of the time, we're not doing chest compressions. That's not so great. I would argue that there's maybe a better way. Even if you do it perfectly, say that you really put your mind to it and you said I'm going to go 120 compressions a minute. That's going to take about 15 seconds. Let's say it takes 10 seconds to do 2 BBM breaths. I get a 60% chest compression fraction. I'm only compressing the chest 60% of the time if I'm just doing 32, 32, 32, and there's no other pauses. And yeah, maybe 10 seconds is a little bit of a long time. Let's put it at 5, which is probably where most people kind of live at. Even if you put it at 5, it's still only 80%. 20% of the time, we're just not doing anything. And that's if you have no other pauses. So is there something that we might be able to do differently with that? And I can't remember what I was going to say here. Oh, yeah. One other thing that's really important. When you pause, look at the ramp time here. So you go from a pause to chest compressions again. And you notice that the first one doesn't generate a whole lot of pressure or flow. And the next one doesn't generate a whole lot of pressure or flow. And neither does this one. And it's only when you get to about, here, about maybe 10 compressions in, that you actually start getting decent forward flow of blood through the body. So you got to do your first 10 compressions just as kind of the priming thing. So if you're stopped, so I'm going to do 30 compressions. I'm going to stop. I'm going to get these breaths. Nothing's happening. It's going to take me 10 more compressions to build up that pressure head again. I'm going to stop again in 20 more compressions. 40% of the time, our chest compressions are doing nothing. We can do better. But again, really important that we do actually manage the airway and that we do breathe for them, because we want tax-paying pigs. We don't want to create a world of surviving but anoxically injured, brain-dead people. So which way are you going to go? Are you going to bag them? Are you going to manage the airway appropriately and take that? Or are you going to go the other direction and kill the single person and spare the other 5 by doing just good chest compressions? Well, what if we did both? What if we did good chest compressions and we did good airway management? Here's how I would recommend it. I need a volunteer, a friend, a helper. This is easy. Come on up, if you don't mind. Let's see. Click here, make sure that we're doing this. 1 second, I got paranoid. All right. All right. So, can everybody see? Hopefully you can. Do me a favor. You be the airway guy. All right. If you'll just bag that patient, and we'll assume that you've got 2 hands on there, you've actually got an assistant for the sake of doing it. So I'm going to do some chest compressions. 1, something like that. Now, if he tries to squeeze the bag while I'm pushing, you kind of back out. And it's probably not the greatest thing. You're not really getting much breath in when you do that. So I'm doing continuous compressions and he's trying to bag. However, there's something different we can do. So I'm going to go 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. And on 10, you squeeze the bag. Okay. All right. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. 1, 2, 3, 4, 6, 7, 8, 9, 10. Now, that's getting the breaths in, and it's getting my compressions. That's kind of a long pause, right? That's a couple of seconds each time. It looks kind of ugly. You're like, lovers, what are you doing? This looks stupid. And I agree with that, but we can change it up a little bit. So same thing. When I hit 10, you just squeeze it back. 1, 2, 3, 5, 6, 7, 8, 9, 10. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. 1, 2, 3, 5, 6, 7, 8, 9, 10. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Now, with a little bit of practice, I can do essentially continuous chest compressions. I do a little bit more of a pause at the 10 just to give him a second to squeeze it in there. But if you got the guy that's squeezing the bag, when I hit 10, squeeze now. Oh, it's okay. Hit 10, squeeze there as I'm coming back up. You'll get that breath in before you get the next one down. And they don't have to be super great breaths. There's already some oxygen, there's some flow going back and forth, even if you're not getting, the full bag in and the full release. But consider something like that. Instead of pausing every 30 chest compressions or every 15 seconds for 5 or 10 seconds, let's do 10 of those and then take a little bit of practice. And you could see even like we were a little rusty in the beginning, we weren't quite synced up. We got a lot better as we went on. This may not be something to try to implement among like a couple of you and a couple of volunteer firefighters who've never seen this before and have no idea what you're doing. But guys at your station you can practice with, yeah, let's get the idea of it. Let's do it one more time. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. 1, 2, 3, 4, 5, 6, 8, 9, 10. 1, 2, 7, 8, 9, 10. Now the other, thank you very much. Appreciate your help. The other good thing that does is it keeps him from being able to squeeze the bag too fast. What's the best thing about the ITD, the rescue pod? It's that it had a little light on the top of it that blinked every like 6 seconds. And you don't squeeze the bag until the light blinks. Nobody uses the rescue pod now. That was a Zoll thing, right? Rescue pod was Zoll, right? Yes, okay, good. I know where my bread is buttered. Let's say that. No, I'm kidding. Nobody really does it anymore. But the best thing about it, and the thing I asked him, like, can you just sell me the light? I'll take the light. I don't need the rest of the thing. I just want the light. The good thing about what we were just doing is that it keeps the bagger from being able to hyperventilate because he's only going to do it every 10 compressions, which is about, 8 seconds, something like that at 120, 10 seconds, something like that. It forcibly keeps them from doing too awful much. So you solve the hyperventilation problem and you solve the pause problem all at the same time. That's pretty cool. Now, yes, sir. Here's the study. Yeah. In terms of are you actually able to ventilate, you can. As long as you do it on the upstroke. You can get it in there. I'm sorry. Yeah. The actual survival study is right here, which I'll get to. So you may say, lovers, AHA says 30 to 2. And if you tell me something different, I got to teach all my people different stuff, and I'm not going to do that. Okay, well, I respect that, sort of. But the thing is that there is actually some data behind it. Here's a trial of continuous or interrupted chest compressions, essentially doing exactly what we said. Does it matter? These guys weren't doing it in as quite a smooth way as we were doing all over, but they're Seattle folks that did it, and it's a Seattle, essentially the same way that they do it. So the way that we do it is essentially what we're talking about here. That was the continuous group versus interrupted. Point is to look down at the bottom and see the data. ROSC looks, the same between continuous and interrupted. Survival, that's going to be better, right? We got rid of all those pauses. We don't have to ventilate. Kind of the same. Neurologically intact survival, kind of the same. In fact, they're all statistically the same. Shit. Oh, I saw that and I thought, oh my God. I'm wrong. I'm a traitor to EBM. I've been teaching this wrong the whole way, the whole time. They were right. I should hang my head in shame and get out. But then, wait, if you actually read the paper, here's what the thing is. Your chest compression fraction is 80% both ways. So no matter whether you did continuous chest compressions or interrupted chest compressions, you were still doing them 80% of the time. You were still meeting the mark. So it's great. They had 4 times when they paused for greater than 2 seconds through the entire resuscitation versus 7 times. That's still great. More than, again, this isn't like 10 seconds, this is 2 seconds. Their pre-shock pauses and their post-shock pauses were phenomenal. They did an okay job at intubating, but they didn't intubate everybody. In the end, same. It's all the same. Whether or not they used interrupted chest compressions or they did continuous chest compressions didn't seem to matter, and maybe the monkey's not so evil anymore. It doesn't necessarily show that I am wrong, and that's the important thing here. that Walt is vindicated by this study is that it doesn't show that continuous chest compressions are better than 30 to 2. It just shows that when you do lots of chest compressions nearly continuously and do them really well, you get good outcomes. So whether you do the interrupted chest compressions or whether you do the thing that I just showed you, which I think is a little bit easier, it doesn't matter in terms of how you're going to survive as long as you're doing it, as long as you're getting the good chest compressions. The best airway and the best breathing strategy you have are the ones that get some air in without interrupting blood flow. And usually in Kentucky, that's a BLS airway. It's probably not BET tube. Ha! All right. I saw lunch is working its way in, so we got that to look forward to. All right. Go back to there it is. Let's go back to it again. We've talked about the airway parts. We've talked about the compression part. Now we just need to talk a little bit about the rest of it. So pauses are bad. Let's just agree with that. Pauses in chest compression is kind of bad. It's essentially like you strangulating the person, and every second that you don't have blood flow going to your brain is a second your brain's like, oh shit, I'm dying. And it doesn't take long for that to happen, for the brain to actually irreversibly futs out. So this is this thing, again, I've referenced it a couple of times, the chest compression fraction. This is the percent of time that you're doing chest compressions. It's also tied to survival. So, where are you? There we are. So, you know, you get 20% of the time, you get crappy survival. If you do it up, you know, 80% of the time, which this little dip is probably not actually truly there, but you got to get, you know, 60% up to 80% or so before you really max out your survival. If you're doing chest compression 60 to 80% of the time, you're probably doing the best thing for the person. One other place outside of pausing for intubation and doing other stuff that we don't talk or we haven't talked about so far is the pulse check itself. That's a huge amount of time when you're not doing chest compressions. Here's one. Let's see. Now you can't hear it. This is in hospital, I know, but it's about the same. Still happens this way. Okay, how long was that pause for? Well, I didn't say it early enough. About 20 seconds. That's kind of a long time. AHA even says 10 seconds. 10 seconds is probably a little bit too long. But this guy went 21 seconds without getting a meaningful chest compression. 21 seconds where his brain had no blood flow to it. And then we try to ramp it back up again. And that's not a completely atypical pulse check, because I saw some people nodding like, yeah, that seems about right. 20 seconds, that's a long time for a pulse check. The average time, at least one study, is somewhere around like 22 seconds. Every 2 minutes, we're going to pause for 22 seconds, take it easy, scratch yourselves, and then eventually get the guy back under chest compressions again. So we need to fix that pulse check. A little bit of data behind it, and then I'll jump into how it actually works. Here's the important parts. If your pause for a shock was under 10 seconds, that's your best survival, but really under 5 is where the real survival comes in. Likewise, if the time that you take after delivering the shock before you start CPR again is more than 10 seconds, survival is in the toilet, and you got to get it kind of down between, you know, at least under 10, if not around 5 or so. Every 5 seconds costs you about 20% probability that you'll get survival out of it. That's not 20. You don't go from 100% to 80% survival or something like that, but you go from 10% survival to 8% survival to 6% survival for every 5 seconds you spend in your pulse check. Now, the first 5 seconds is kind of baked into the cake. You can't really get rid of that, but the rest of it is something we can probably do something about. One more time with feeling, the amount of time that you spend doing your pulse check makes a difference, even in how much you defibrillate the person. So if it takes you under 10 seconds, you got a good chance of defibrillating the guy. That drops down to 3/4 if you spend 10 to 20, and if it's more than 20 seconds, 60% to 40%. Just the amount of time that you spend doing the pulse check makes a big difference in whether or not you're going to be successful in shock. So I've got a big thing here written up, and we'll kind of just jump in and do one of these. Basically, we know we have a pulse check. We go 2 minutes of ACLS stuff, we do another pulse check. 2 minutes of ACLS, pulse check. What happens in that pulse check? There's a lot of stuff that happens, as we kind of mentioned before. This is, again, all the stuff I could think of that actually has to occur during the pulse check to meet the end result, which is give a defibrillating shock or start CPR. Those are the two outcomes of a pulse check. You're either going to do CPR again or you're going to give a shock. And this stuff all has to happen in the meantime for that stuff to occur. I got ahead of myself. You can go ahead and do whatever you can to drive to these two things without having to pause for 15 seconds, 20 seconds. We can do it faster. Number one is you got to have a plan. You know it's coming. This is one of the constants in medicine. Every 2 minutes, you're going to have a pulse check. If I tell you every 2 minutes I'm going to hit you in the face, how long is it going to, how many times am I going to hit you before you realize, hey, every 2 minutes, I got to duck? You can make a plan ahead of time because you know it's coming and you know exactly when it should be coming. When you do it, you need to prepare for it. It's not something that you can just jump into. You may have heard the pit crew analogy before, but you'll see all these guys prepped and they're ready to go. And I won't get into the whole pit crew thing, but here it goes. You want your pulse check to look something like that. That was pretty sweet, huh? You got 4 new tires. I think you got the stabilizer changed. It's all because they had a plan and they were prepared for it. Unfortunately, most of our pulse checks end up looking
time to refuel and change tires. Lumore himself changes the tires.
There's somebody's got a
Only 4 crew members, including the driver, are allowed to work on the car. It's a tense time. Holland stays in his seat, anxious to get away. Let's watch.
So whereas the Florida one took like 4 seconds, this guy's gonna get the same thing in just about 50 seconds, and he's back at it. Same thing here. Here comes a pulse. There's a pulse check that's coming up here, and I think I know that guy. You will find that everybody is just kind of looking around. Nobody knows when the pulse check's coming, or at least nobody acts like they know when the pulse check's coming. And subsequently, the pulse check is not going to be very good, and it's going to take forever. I'll skip over it. Let's look at a pulse check. Could I grab a couple of people? I think this is the last thing we got before lunch. Yeah, maybe 4 people. 4 people haven't worked yet. How about the back table? You guys want to come on up? Yeah, get a whole. Get several. All right. All right, so you guys are gonna, you'll do some chest compressions. If you don't mind bag, do it just like you would normally do it. We're starting out, we'll say 1 minute and 20 seconds into a cycle. So you've done a minute and 20 seconds of CPR thus far, and we're gonna do all that. So if you guys would show us your best pulse check. And if it's not great, that's okay. All right, guys, so you might kind of think like, well, there's a little bit of, maybe there's a ceiling effect that kind of happens with the normal stuff that we do with the pulse check. Because what do we have to do with the pulse check? Well, there's all kinds of stuff. You have to look at the rhythm. Come on there. There we go. You have to look at the rhythm. You have to like identify the rhythm. You got to get everybody's damn hands off the patient so you can deliver that shock. And well, maybe you actually don't, but there's a lot of stuff that you're supposed to be doing during a pulse check itself. Wrangling all these people is kind of one of it. So if you lock everybody up here, let me just give you an example of the way that I would kind of recommend managing all these folks. You got somebody doing compressions. You got somebody doing the airway 1. You got somebody squeezing the bag. You got somebody who's maybe the team leader. Somebody giving drugs down here and somebody with a monitor over here. Usually probably pre-hospital setting, that guy is going to go, and there's some volunteers standing around. There's the guy with the monitor. He's more towards the head. All right. Number 1, I'd recommend you give a warning. And I'd recommend you give a lot of warnings, because when you guys were doing it, just on objective opinion, did the 30 seconds really help? Like, did you know what space 30 seconds was? Other than like 30 seconds, it's a number, but does that really mean a lot to you? I'd probably say for most people, probably not. It's like, okay, 30 seconds, there's a warning. And that warning is fine, but I could have said grilled cheese, and it probably meant about as much. It's like, oh, that means that I got to start getting ready for a pulse check or something like that. Certainly, we need to give warnings, and we need to give lots of them. We need to continuously update. I say 30 seconds, 10 seconds, maybe 5 seconds, and then pause itself. Unfortunately, for the most part, a lot of times our pulse checks look something like this. Oh, let's see. Like all of a sudden, oh my God, pulse check. Where'd that come from? Well, I've been saying to you for the last 30 seconds, man. What have you been doing? Well, I've been doing chest compressions. I've been working hard. I've been burning 1,000 calories an hour doing chest compressions. That's what I've been doing. So I say give everybody 30 seconds, tell them 10 seconds, then tell them at the time itself. Now, my warnings are a little bit different than everybody else, I would say. There's some stoplight stuff that we can kind of do. 30 seconds is the first warning. 10 seconds is the yellow light. And then when we get to the red light, yeah, we're going to stop. Please don't go through that whole thing. Sorry, you got to watch those lights flash for a minute. Come on. There we go. All right. So, it's a number. It's a round number. Yeah, for the most part. It was in that thing at the beginning, like the Conehaven thing, you basically said, like, it's probably prudent to check every now and then for the presence of a pulse, or that systole has resumed. Okay, cool. Yeah, it's mostly a number. If anybody's got an actual data to go against that, I would say show it to me. All right, in that 30 seconds, when I hear 30 seconds, I'm thinking, all right, I'm gonna get ready for this pulse check. Let's go ahead and pre-charge the defibrillator number 1, which we, I think both groups did it at some point here. Let's get the defibrillator charged up, because how long does that thing take to charge? About 10 seconds, thereabouts, they're around there. Unfortunately, if you wait until you're gonna do if you wait to charge it up until you identify that you have the thing, that means you either gotta wait 10 seconds or you gotta start doing chest compressions again. Now, if you do start doing chest compressions again because you forgot to pre-charge the defibrillator, that's actually okay. What I would probably say is then don't do 10 chest compressions, don't do 5 chest compressions, don't do 15. Say, if we have to start chest compressions again, we're gonna do minimum of 30, because that will actually give you some perfusing blood back to the rest of your body. Remember, 10 seconds of chest compressions does nothing. 10 seconds of chest compressions primes the pump, but doesn't actually move blood. When you get to 30 seconds, you've at least had some time there. And then one of the other things is if I'm doing 30 chest compressions, I know it's coming, I can just hover my hands up, he can shock them, and I'll jump right back on it. So if you haven't pre-charged the defibrillator, if you start chest compressions again, don't stop for 30 seconds. Just keep on going. Or 30 chest compressions, or however many it is that you want to do. But don't do just like 7 and then kind of stop. That doesn't actually help. But if you pre-charge the defibrillator, then it's ready to go when you're ready to shock. And you can shorten just complicated slide, but basically, if you don't pre-charge the defibrillator, you spend about 30 seconds not doing chest compressions. If you pre-charge the defibrillator, you spend about 15 all told. Now, is it safe to pre-charge the defibrillator? Yes, the thing is not going to go off on its own. You can charge the thing up. Even if it were to fire, there's actually, I don't know if you've seen it, it was popular a while ago until somebody got a little bit shocked with it, but hands-on defibrillation, doing defibrillation during the chest compressions, that's a thing. Most people end up just fine. If you've ever actually brushed up against the bed, like when somebody gets shocked, you're okay. Even if you hook a wire up to somebody, it's okay. Anyway, if you charge the thing up ahead of time, then you don't have to think about it, and you don't have to do the pause. So pre-charge it, either pre-charge it or charge it during chest compressions, but don't charge it when there's no chest compressions going on. You'll be fine even if it does go off. Now, how about when you get to the actual thing itself? What takes up some more time? Well, it's feeling for the pulse. I would say between charging the defibrillator and feeling for the pulse, that takes up most of our time in our long pulse checks. Because it's always, oh man, I think I feel a pulse or something like that. On average, 22 seconds to detect a pulse for somebody in CPR. That's to feel, yes, I definitely feel a pulse. And part of that is when you get your hands off the person, their heart is kind of like, it's still a little stunned from you squishing it so much. It may take a second to kind of go like, oh yeah, I actually got a beat again, here I go. But you spend about 22 seconds each time before somebody definitely says, yeah, I now feel a pulse, definitely. And if there is no pulse, that's kind of bad. Our fingers also suck at this, but that's a story for a different time. I will tell you, I don't think we should necessarily do a pulse check each time. I think you should do a rhythm check. And AHA actually agrees with me on this for maybe different reasons. Hard to see that at the top, but you can kind of see the squiggly line up there on the EKG tracing. Now, is that ever going to have a pulse with it? Yeah, that particular rhythm is never going to have a pulse. If you see that, there is no pulse. If you think there's a pulse, you're wrong. So why worry about feeling for a pulse when we know what this needs? We see this. This needs electricity. Even if you did have a pulse with it, it's not going to for long, so just shock it. So you see that? Just shock it. How about this? Is this ever going to have a pulse with it? Nah, as long as your leads are on, never going to have a pulse. No reason to feel it. You know, and again, you put somebody on there, somebody will say, oh, wait, I think I feel a pulse. No, you don't. There is no pulse. It is not there. So why do a pulse check for this? Don't worry about it. How about this? Could this have a pulse? And could you potentially feel it and maybe do other things that are more important, that are more effective than closed chest CPR? Yes, potentially. So if you see an organized rhythm or something that might have a pulse with it, okay, this is a time where we can say, all right, let's now feel and see if there's a pulse with it. Don't spend too much time with it, but get rid of the idea that, like, we're going to do a pulse check each time. Yes, sir. On VT, I would say very little, because what are you going to do? Like, they're unstable at that point anyway, probably, right? So I would likely just shock them again. I don't know if I've ever actually encountered VT in an arrest, like that I didn't know was coming, like somebody converted into it. So yeah, reasonable point though, like how long are you going to check for it? You could look and see, because there's a chance that it's going to be something else, just a wide complex AFib or something like that. Certainly 10 seconds and kind of leave it at that. But if I got to the end of that 10 seconds, I'd be like, all right, if I don't feel anything real fast here, we're going to light him up, and be kind of nervous about it the whole time. Kind of not nervous, but bitching about it. All right, whoops, I forgot my summary slide. So don't forget, for the pulse check, make a plan. Know where everybody's gonna go. That's the same thing. I don't know if you guys could hear it, but everybody said, you know what we need to do? We need to make a plan. We need to have good communication before the pulse check happens. And probably the time to make that plan is before you go out on the run, but at least in the 2 minutes ahead of time. Charge during the chest compressions, you'll get money out of it. Do a rhythm check instead of a pulse check, and don't get hit in the face. Don't be surprised by the pulse check. However, I'm just giving you ways you can do this. This is ways that I kind of like, and if we drilled on it, and we did drill on it in the hospital for a while, and we got our pulse checks down, 5 seconds, something like that. Oh, I didn't include that video. That's a drag. I was going to show you our success. We did really well with it, but it took constant training. It took a lot of time, and it took constant retraining. So remember, this is something you're going to have to do over and over again. I have a couple of minutes until it looks like lunch, although lunch is back there. So I'm going to finish up this little bit. The Lucas. We grabbed the Lucas. You all have had the Lucas since I became your medical director. Before that, I didn't bring it. Y'all had it at the time. Y'all like it? Everybody, I think it was maybe a year old when I came in, and everybody was like, yes, we love this thing. And I like it too. Where'd it go? Here it is. It's cool. It's sleek. I like the green better, but whatever. Like, look at this thing. This is a thing of beauty. I know that data doesn't support its extensive use. There's not data to say that it is better than the best human CPR. It didn't happen in the LINK trial. It didn't happen in the paramedic trial. It didn't happen in the CERT trial. And when you put them all together, if you don't read a lot of analyses and stuff, basically this line in the middle is the no difference line. And if your block or your line touches that no difference line, there's no statistical difference. Maybe even favors manual CPR a little bit, maybe. I know the data doesn't necessarily say that it is going to be better than something else. It's probably the same. But the key to me is that it's probably the same as the best human CPR. If you're doing really great CPR, it's probably the same. Tara, I didn't even recognize you, dude. Hey, man. It's probably the same. But the thing about the Lucas is it gives you the best human CPR, and it's consistent. It doesn't get tired. It doesn't fatigue. It frees up a rescuer, and if you're in Eastern Kentucky and you've only got 2 people on the run, that's a big deal. And it's the only feasible way to move somebody under active CPR. That part I am sure of. There is no other real way to move somebody under active CPR. Again, they put a pig in an ambulance and drove around with it. Here's the chest compressions with a device. Here's the chest compressions with just your hands. Crappy compressions, good compressions. Good compressions, and not so great compressions. Same thing. Here's blood. It's blood flow, cerebral perfusion pressure, end tidal CO2, and lactate. Lactate's a little higher. Basically, better blood flow when you have the Lucas on the pig while you're moving. It is, in my opinion, the only way to move somebody. The problem probably comes in that we have a little bit of issue with getting it on and with maintaining it when it fails or when it hiccups. Let's call it that. Can somebody do me a quick favor? 20 minutes. This way. Here. Let's get 4 more people. Any 4? 4 active folks. Sweet. It could even be 5 people. Call up a friend if you want. Now. Oh, it didn't work. That's okay. All right, what I would like for you to do is put the Lucas device, basically let's do some chest compressions, let's bag the person, and let's put the Lucas device on him. And again, if you think you need more people, just pick a couple of people out and all right, what do you guys think? Pretty good? Pretty good. Yeah, I was hoping you guys would suck at that a little bit more. Unfortunately, it doesn't always work out that way. So, can you guys turn around for a second? Explain to us what y'all did. What's that? Communicated, okay? Love it. Okay. All right. I'm sorry. Roles. Everybody had their job. Didn't get a whole lot into other people. Knew about the thing. Yes. Played with it. You guys have gotten out the Lucas device before. Yeah. All key things. Yeah. All right. You guys did really good. There were a couple of really good points here that I want to kind of talk about. If you'll assist me in doing so. So, the device itself. Let's look at it real quick. First, it's got 2 kind of parts. The back plate comes out. Oh, there was one thing that you didn't do that I'm going to get you on in just a second, but good job overall. So it's got this, it's got like the plunger part, and then it's got the back plate. getting the back plate on is, for you guys, was pretty easy. What did you guys do to get the back plate on? Just kind of picked him up, yeah. Okay, cool. You'll see people kind of, pull this out for a second. You guys did all this stuff really well. You'll see folks try to roll the guy. Can you grab that for a second? And just place him, go ahead and push it in your cell and be like, all right, I'm gonna pause CPR, we're gonna roll the guy over, okay. And if you'll stick the back plate back there, his arm actually props him up pretty well. But most people, when you get them up, they're not like this little trim ambu guy. They are, well, they look more like me. There's a lot of stuff in here. And you can't really roll them over very well. It gets hung up on like the underarm flap and that kind of stuff. So that doesn't always work in my opinion. I think what works a little bit better is the following. If you'll take that back. All right, if I could get one person over there, just on the shoulder is fine. All right, so I'm gonna do chest compressions. And what we're gonna do is just lift him, we're gonna bend him at the waist. I'm gonna sit this guy up. All right, so I'm gonna do 10 more chest compressions and we're gonna do it. 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. We're gonna sit him up. Now you slide that back there and put it right down there. That gets the guy up. There's no back flub in the way. There's no clothes in the way. Now you've got the plate back underneath. You can kind of, if you time it right, if you aim it right, you can sit him up. Oh, I lost his wig. Tuck the thing behind him, right underneath his arms, and set him back down right on top of it. Pretty cool. That works pretty well in my opinion. I don't like the roll. I think the roll is kind of unnecessary. But grab him, lift him up by the shoulder, sit him up, and then lay him back down on top of it. Now, the next part is getting the actual thing on. Now, as these guys said, they had it on ahead of time. They've had it basically ready to go. We can hit that thing, it'll start like that. Want this thing primed and set because I don't want to be messing with it a whole bunch once I get it on. Can you guys demonstrate the way that you did the chest compressions a second ago? And how you guys put on, how did you guys put it on? Everybody see that? If you haven't seen that before, yeah. Good, so what he's done, clip on the one side first, spread, yeah, great. He's got his arms kind of spread apart and the suction cup can actually be higher, like that, yeah. And he can still do CPR, like, is that real comfortable? No, it's not. It's not super great, you don't want to do it for a long time, but it'll work just fine for right now. I can even lower the suction cup down and get it basically ready, right till it's touching the top of his hands. He's still at least doing a little bit of CPR for a second. But then we're a little bit too far down on the dummy just for the sake of making it look good. As soon as we can get his, we'll say, all right, you ready? And in 3, 2, 1, move, push the thing down. And there you go. By the way, if you haven't played with the device much, there's that little pause that you hit the play button and then it doesn't do anything for a second. That's what happens because it's setting itself, it's centering itself. If you hit the other button first, the pause button, it won't do that. It'll start a little bit faster. But there's always a little bit of a hiccup there. It doesn't mean it's not going to work, but there's always that tense feeling of like, oh God, it's not working. Push another button, push another button. Don't push another button. Just let it go for a second. All right, what if you have a problem with the device? Get it out of the way. Get it out of the way for a second. My advice, and I don't know if this is covered in the company literature or not, but my advice is don't try to troubleshoot it in vivo. If you got a problem with it, pause, DC, chest compressions right now. That's okay. Don't worry about it. Because no benefit compared to great human CPR. Crappy human CPR is something else, but just keeping the thing in place is not really the goal of it. Keeping the thing in place and doing that good CPR is important. But if you got to spend 30 seconds screwing around with the thing and it's not working, yeah, not worth it, not worth it. So if you have a problem, the thing comes off really easily. And we can just go right back to chest compressions. You can turn the thing off, you can reset it all, and then just do exactly again. Because you saw when you guys did those tests, when you guys applied the device itself, you didn't really pause chest compressions for more than, once you got the backplate on, what was the pause? Like 2 seconds, something like that? That's pretty good. So if you're going to use the thing, and I suggest you do, because I like it. I don't own any stock thanks to Stryker. They did sponsor us. Yay, Stryker. But it's not that. I think it's a good product. I think it is a great way to move people. I think when we get into the future of resuscitation, you'll hear about it more because it's going to be the only way to get somebody from point A to point B under active CPR. Cool. Well, thanks you guys for doing a really great job. But I didn't have much to talk about. So you guys are awesome. Oh, sorry. Yes. The one thing that they didn't do, that they are bastards for not doing. What's this? It's the neck strap. Has anybody ever seen this get put on somebody? I haven't seen somebody come into the hospital with it. I wish that they had put it on. It goes behind the neck, and then it keeps it from walking down the belly, because the thing will walk down the stomach a bit and end up kind of down here-ish, and that's not really where it's supposed to be. And in fact, I've been involved with a legal case where they said, that's in the wrong spot. Like, yeah, but that's where it always goes. But it's in the wrong spot. And they had an autopsy photo of the guy with the circle right there, like over his xiphoid process. And like, that's what happens when you don't put the thing on. So once you get the device on, you're going to have to go find the neck strap wherever it is that you after somebody got it out of the case. But use the neck strap. It will make the thing work much better, and you don't get that like walking down the chest, and now we're doing like stomach compressions. Cool. All right. Thank you, guys. All right. Let's do this. I'm done with my little bit here. Are you? I think maybe just have everybody grab a box lunch and listen while you're, or eat while you're talking. Is that cool? I didn't want to. Hey, good. All right. That is the master class on resuscitation, for what it's worth, from Walt's standpoint. We have an actual critical care doctor joining us, Dr. Taryn Trott. You're at UK, yeah? Where'd you go? Where were you before? Where'd you do your fellowship? Philadelphia. So he's been around, but he's a Kentucky boy, and he's one of the coolest guys that you'll meet. So I'm really looking forward to what he has to say here in just a second. Lunch is here, and it's lunchtime, and we got a little started, and I didn't do a good job of shortening things up. So let's do this. Let's grab lunch, come back, and we'll get Terrence set up, and we'll have him go. And that way, we'll take a break after lunch, or after his presentation. Awesome. Thank you, guys. Buy a beer, please. Drink something.